What do we know about A-fib, and does what we know support the way that we treat it? I'm not 100% sure, and maybe at the end of this you won't be either. First things first, what is atrial fibrillation? It is an irregular rhythm caused by improperly conducted impulses from a fibrillating atria. Done deal. So what do you think of when you see A-fib on the monitor in a patient who is presenting with symptoms, right? Tacardism or not tacardism? 90% of the people who are on the truck think of it this way. You're not alone if you do, it's all right. But one thing we don't always think about is, what is the underlying cause of A-fib? What brought this on? There are a lot of acute conditions that can bring on acute A-fib, and then there are also long-standing conditions that can bring on A-fib at some point in time, and when it happens, you are more than likely to be called to it if the patient's manifesting with symptoms. So let's just talk about a few of them. Hypertension, okay, particularly unmanaged hypertension. An MI can bring on A-fib during that new onset MI. Coronary artery disease can do it. Of course, we all know about heart valves and stuff like that, but think about pulmonary embolism. A PE can bring on new onset A-fib. So A-fib can present with dizziness, it can present with shortness of breath and sometimes chest pain, but what also can? A PE also can. Pneumonia can also do this. Exposure to stimulants, especially long-term exposure to stimulants. Alcohol is included in that, okay? So caffeine, tobacco, alcohol, and then of course your harder stuff that is in the illicit drug category. Lung diseases can also do this. Viral infections, heart surgery, and sleep apnea. That's one not a lot of people think about, sleep apnea. So how common is A-fib? If all these things can bring it on, how many people have it? Well, probably more than you would initially think, and I included a really good study in here. I encourage you to go check it out. But it found up to 9% of people who were between 80 and 89. 9 out of 100 people presenting with A-fib, documented A-fib. That's something. So A-fib comes in different categories. It's not just A-fib and have a good day. You don't just go into A-fib and stay there forever. It can be paroxysmal, like PSVT. It can be persistent. So the heart rhythm doesn't go back to normal on its own. You know, sometimes it's going to need some intervention. You can have long-standing persistent, okay? It's continuous and lasts longer than 12 months, so you're in A-fib a year. And then you can have permanent, all right? And I included a source from this because some of this stuff just needs to be backed up when I condense it down in this manner. So how do we treat A-fib? What is our category? Well, it's got to be new onset, less than 24 hours, patient symptomatic, no matter what, right? No matter what. Well, that's not exactly how they treat it in the hospital, and it's not exactly how physicians treat it. Physicians can allow a patient to stay in A-fib for an extended period of time while they're administered, say, anticoagulant medications, and I mean up to weeks, while they're being started on these different regimens of medications, and then can bring them in to convert them days or weeks afterward. So I bring this up because sometimes we have a patient who really could benefit from an antidysrhythmic. Their A-fib is symptomatic. They're not doing so hot, but we just don't have a way to confirm that it was within 24 hours, right? Because what do people tell you all the time? I've been feeling bad for 2 or 3 days, and it makes you kind of reluctant to pull the trigger on that drip because you don't want to throw a clot or something along those lines. I'm not going to get into clotting and how everything like that works, or chances of this or chances of that, but this is what I will tell you. Physicians usually understand this much better than we do, and they usually had a lot of different treatment options at their fingertips. Don't rule out cardism just because it's of the onset time or you're unable to confirm the onset time. Get in touch with the physician you're delivering to, or whatever the appropriate medical direction you have in your area is, and tell them what you have and ask them if you think cardism would be appropriate in a patient who seems to be failing or doing poorly. Their answer may surprise you, and at the end of the day, the worst they can say is no. So that's something to think about. Get out there and practice.